Hi, Veronica. Can you hear me?
I can hear you.
Perfect. Yeah, it muted me upon entry. So that's good. When people enter, they're muted automatically. I had to turn my mute off in order to talk.
Got it. Okay.
If for some reason you can test if you think you hear someone who's background noise, you can mute them. So you could mute me. Go ahead and try to just mute me.
Let's see.
You have to go to my name under the participants.
Right. It says, oh
As
yeah,
a,
I see
yeah,
it.
as a host, if you hear
Got it.
a bunch, yeah, you can mute me.
Okay. There's one more person waiting to come in. Should I just wait till the end to
Oh,
admit?
who is that?
Ri Wang.
Oh, yeah, wait, they're not part of it. Yeah, so you're only gonna let in the people who are moderating and speaking. So when you see Tom Gregory, you want to let him in. When you see Megan Schimpf, you're gonna want her in, and then I think her assistant Brian is supposed to log in as well. Let me get his full name. That's the
Wait,
one who we did the test with, remember?
right, and wasn't it Steve, or was that somebody else?
Oh yeah, you can let Steve in as well. Steve Manalia.
Yeah.
Who was it? It was Brian.
Oh, I thought, okay. It wasn't Steve that did the test with Tom?
No,
Oh, okay.
it was Megan Schimpf's assistant, the one actually gonna run everything.
So the other people, they don't get admitted. They just,
They're just in the waiting room until all of us are okay, everyone good, and then we'll be okay, you can, and then you can let everyone in all at once. Because
okay.
we're gonna do talk shop with people when they log in and
Right.
test the mics and stuff.
But the admit, I have to manually hit admit for every single name, correct? Or is there a way to do it in a group?
Yeah, you can do it in a group when you're ready to go, but if you have to do it individually, when you see Tom and all those.
Yeah.
You can hit everyone at once.
You can. Okay, I don't know. I don't see that option, but maybe it's because there's not enough people in the waiting room yet.
You'll see it as an option.
Okay, great.
And then during the demo, during the webinar, you'll see other people join and you'll have to manually admit them.
Okay.
Come in.
I'll keep an eye out for that.
Yeah, and you'll get a little pop-up.
Mm-hmm.
I'm trying to think of what that guy's name was. I thought it was Brian. Hold on. Oh yeah, if you see Brian Hurd, let him in.
Brian who?
Hurd, Hurd. Yeah.
Okay. Got it. Tom, Steve, Megan, Brian Hurd. While I have you, Abbas asked about the publication date for the vaginal energy. Do we know? Do we have an estimated timeline for that? Or does it depend on when the pubs committee, I guess, approves it?
Yeah, I mean, it's going to be a while because it has to go to back to the pubs committee, then it has to go to the board, and then to the journal. So, I mean, not for a couple months. It's not going to be published before the Augs at Yuga meeting.
Yeah, definitely not. Okay, so I'll just tell him that it needs to go through various rounds before I can give him an estimate.
Yeah, just say it's going to be probably a couple months,
I think.
But what I don't know is are we allowed, once the board approves this, can we post on our website before it gets published in the journal?
If you're doing a published ahead of print.
Okay, yeah.
But I don't know if this is one of those. I mean, I guess
I think it would be, yeah.
They want that?
Yes.
So when I send it to the publications committee, how about I ask them if this is something they want to push forward as a published ahead of print?
Yes, that's perfect.
All right, let me write this on my to-do list. Hold on a second.
Sorry, I'm also eating my lunch at the same time.
Yeah, I would never know.
Yeah. Do you eat like on Eastern time or Pacific?
Pacific. So I had breakfast like a half hour ago.
Mm.
And then I have like a late lunch after I get off work, like usually like closer to 3.
Ah.
Yeah, just because it's like I go to bed so early that like I usually have like a very light dinner and then it's like go to sleep
Yeah.
early. Otherwise,
I mean,
um,
it must be so nice to like basically technically get off at 3. Like you have so much of the rest of the day. You can like run errands and like go like do any doctor's appointments.
that's what I love
I
actually.
know. I like wish I had that schedule, but I don't think I could get up and start working at 6 a.m.
It's a huge bonus. You just have to kind of be disciplined to go to sleep early, but other than that, it's great.
Perfect.
I don't see anybody else on, just keeping an eye on that. Hold on. Do you have anything fun planned for the long weekend?
No, nothing, which is awesome. I need to just do nothing. I'm just like so well, I mean I need to like do work.
Right.
And try to catch up because I was out yesterday um getting stuff for like Gemma and back to school and all that stuff. Um so I just had like a lot of stuff to do. But yeah, I'm hoping just to like do nothing and chill. What about you?
Same, just relax. That's
Yeah.
my plan. When does she go back to school?
Tuesday, just right after Labor Day.
Oh, wow.
Yeah, which would be good. Just these past 2 weeks and coordinating with her and all that stuff.
Okay. Is she excited?
Yeah, I mean, she says she is. I'm sure it's going to be a terrible drop off because she's when we
Maybe
drop her
not.
off. I hope not. It's so heartbreaking.
Does
'Cause
she have
she's
friends
really,
there
like,
yet?
yeah, she has 2 friends there, but everyone else is new because it's a new school.
Okay.
I'm sure, she basically screams like someone's being kidnapped. It's just like the mom guilt after is very
I
hard.
know.
But then again, like I can't stay at home with her. Like I would go crazy. And then
Of course.
and she needs a socialization in school. Like she's done so, compared to other friends I have who like their kids stay at home, like Gemma's talking more. She's, doing a little bit better with that, than other stay-at-home kids. So
Right.
even if I wasn't working, I would still want her to go to some type of school.
I have 2 friends who have like 3-year-olds, and separately, they all have like speech, I guess, development problems. Like they're not speaking, I guess, the way other 3-year-olds are expressing themselves.
Hmm.
But it's just, I think like they put too much pressure on it. Like kids will develop, that ability within time whenever they're ready.
Yeah, that's true.
Yeah.
I know we know like a 2.5-year-old, she only says like a couple words. She's like a stay-at-home, doesn't like get around any other kids. But yeah, I'm thankful that I don't have to like deal with that side of it.
Right.
I'm like, Gemma has like full on conversations. I'm like, you're talking like
It's amazing.
oh my
It's
God.
not her challenge.
I know.
Okay, Megan Schimpf is on. I'm going to admit her.
Oh, perfect.
Hi, Megan. Megan, can you hear us?
Oh, I think she's still like dialing into the audio part. Or she just put herself on mute.
Hold on, let me take her off. Yeah, I can unmute her.
Well, they're probably.
I told you I found mine, right? I stepped on it. The one time I went in there.
Yeah.
Did I not unmute her?
No, you didn't.
Okay.
She muted herself. They did that on purpose.
Okay. Brian Hurd is on. I'll accept him.
I just typed in a little chat welcome so everyone could see.
Oh, yeah, I see that.
But like when attendees come in, they'll see it.
Got it.
So I always have to, like, if I want one-on-one conversations, like you have to hit that drop down. Like you could just chat me on this separately.
Can I?
Mm-hmm. I can send something just to you. Hold on.
Well, I can still use, I guess, instant messaging, right? Separately.
Yeah.
Oh, I see. And how'd you do the private? Just, oh, you selected my name.
Yeah. At the bottom of the chat,
I see it.
okay, but like two, and then you'd have to just choose me in the drop down.
I see it. Okay, perfect. So many little features.
I know.
Okay. Let's see.
Hi,
So
Brian. Are you there?
Hello, yep, can you hear me?
Perfect. Yeah, we can go ahead and make you, Veronica, if you want to work on making Brian the co-host. Brian, will you be displaying the slides from your user on Zoom?
Yep, and actually I was gonna see if we could just do like a practice share to make sure that it comes across. Okay,
Perfect.
Okay.
So Veronica, you'll want to like hover over Brian's name and there should be an option to make him,
I just did it.
yay. Done.
okay, cool. All right, so I'm gonna hit share. No application. Okay, and are you guys seeing the PowerPoint? Okay,
Yes.
in like presentation mode now?
Yep. Presentation mode. Everything's good.
Okay, cool.
Yeah.
All
And
right,
what we'll do, we set up the Zoom for everybody to be placed in the waiting room upon entry. So once like all of us are good to go, we'll just say, okay, we're going to let everybody in. And we're going to let everyone in at once. So, but we'll do that as we get, as we get closer.
okay, sounds good.
Yeah, we can hear you perfectly. No echo. Everything sounds great.
Awesome. When I get into the room, I'm gonna hook. We have like a microphone system and a camera system in there, so the audio might change a little bit, but it should actually be better once we're hooked into the system.
Great.
Colleen, I got a couple more requests about the link, which was really interesting because it worked for you when you registered. So I just sent those people the invitation.
Yeah, go ahead and forward it to whoever. That's really weird.
It is. I don't know if that's happened before.
Unless you want to email the link out right now, just in case. You know how you sent everybody yesterday those articles or Tuesday?
Right.
You could just email everyone, hey, just in case you need it, here's the link.
I can do that.
You're able to do that because it's not like we're seeing your screen right now.
Okay, hold on.
You can, I don't know if you can just reply all since it was the BCC.
Here's Tom, Steve McNally. All right, so Steve and Tom should be on now.
Okay.
Hey, hello everybody.
Hello.
Hi, Tom. How are you doing?
I'm okay.
Good to see you.
All right, looks like my video's working. We'll bring a couple people in here in a few minutes. I'll stop my video for a second.
Yeah, I'm good.
My sound is okay?
Yeah, you sound perfect. No echo or anything. And we tested Brian sounds good and, the Michigan people.
Okay. Awesome. I always have to, the one part about this Zoom conference is I wish the chat font, the chat room font could be made bigger. And the only reason that is because I look at it from across the room, and so it's not like the same font as the presentations, and so.
Oh, yeah, that's a good point. Yeah, I don't think there is a way to do that.
No, I've been trying, and I have not succeeded, so I'll I will probably, after we get going, turn my video me off so that when I'm squinting at the screen trying to see what people are saying.
Yeah, because you can make the chat box larger, but
Correct.
not the font.
Correct.
And I'm literally like right in front of my laptop, so I'm fine with it, but the others.
I'm sure most people will be, except for the people who are like in the conference room. So depending on how big the screen is that Brian has set up, and then like us, I'm just using my 30-inch Mac. But even still, like we sit around a table, and everything looks great. It's just hard to see that part. So that's okay. And I should be able to see participants. So I see Veronica and you are both on, and Steve is kind of on, is he?
Yes, he is.
And do I actually have, when I see somebody raising their hand, can I unmute them myself if I want to talk to them?
No, I don't believe so. I can try. Hold on.
Which is, I just need to have you do it somehow, I guess.
Yeah, if I see someone, actually, yeah, Veronica and Brian, they're like both hosts. So Veronica or Brian would have to unmute the individual.
I can keep a lookout for it.
Yeah, so see Veronica, like that little blue hand.
Yep.
And then I'm gonna lower it. It goes away.
Hey, Colleen, I can't see that email that I sent from the OGS info with the 2 articles. It's not in the sent box to try to resend those people the link.
Oh, did I got the email though, right?
Yeah, I mean, I sent it for sure. I just can't find that sent email with all
Oh
of
yeah, it's gonna be in your inbox sent folder. Not the info, but like your personal.
Ah, okay.
Yeah, yeah.
That makes a difference. So we have 6 participants waiting.
Okay.
And you see that, okay, because you guys are the hosts, you can see them hanging out.
Right.
Yeah, and once we're kind of like all ready, well, you know, like we did last time, we'll say, all right, we're gonna let them all in and then start. So we got 6 minutes.
But Brian has to pop into his conference room and get everything set up before we get
Correct.
going, right?
Yeah. Yeah, we'll all say like we're good. We'll make sure everyone's good.
Tom and everyone, can you hear me?
Oh yeah. Hey Steve.
Okay. Yeah, I joined on the phone, but it had locked me out from the audio, so I couldn't hear anything if you guys were talking to me. But
Okay.
It says if Brian, I don't hear Brian.
Yeah, I don't hear Brian either.
No, he's just texting to us right now.
Hold on, let me see if I can, hold on. No, I can't hear, and he's not on mute either. We heard him before.
Yeah, Brian, make sure that you're connected through, I guess, either the phone or computer.
Who else coming? Elaine is coming.
Us 3.
All right.
Like mini.
Can you hear me now?
Yeah.
Yeah.
Okay, cool. I'm gonna head over to the conference room, so I'm gonna turn the volume down over here for a few minutes just till we get connected and everything, and then we should be good to go.
Now, you folks at Michigan, are you going to just start with the announcements and housekeeping since I can't advance the slides? Because Tom, I'm moderating, right?
Oh,
Or are you moderating?
you're welcome to. I was all. I guess we kind of have been co-moderating, but if you want to do it, feel free.
No, hold on a second.
I can do it because I'm set up pretty well.
Can you hear me still?
Yes.
Yeah, I'm okay with that. I mean, I'm prepared as well, but that would be great. I just came from a deposition and now I'm in a hotel room, and so
Oh.
I got your notes in front of me as well as some of my own notes.
Yeah, I
but-
don't think that they're gonna use much of our notes anyway. They're gonna do their own. Well, we could be prepared in case.
What article are we starting with first? The Vaughn or the Carter Brooks?
I think it's the
Hi,
Vaughn.
everybody. Can you hear me?
Yes, I
Yes.
can.
Oh, great. Brian's just getting the computer hooked up so that you can, so that we're technologically compatible with the room. So we should be ready to roll in just a couple of minutes.
Great. No
Is
problem.
one of you guys going to go through the announcements, or do you want me to do that?
Okay.
I think either Steve or I will do that.
Okay. And then Dr. Delancey has a few slides that he's going to do for background. And then we are going to do the Carter Brooks article first. No, I'm sorry, I lied. The Vaughn article first.
Okay, good choice.
That was
Which one are you looking for?
there's a USB.
Be the typer.
Can you still hear us now?
A
Yes.
little further away, but yes.
Okay.
I'm going to show our room. Whoa.
I'm gonna,
There's definitely echo there for a second.
yeah, I think I fixed it.
Okay, cool. We'll probably be the only ones. Yeah, they'll pop some people. I bet Blake will come on and be, sitting there picking his nose.
I got to sit in on an official Echo presentation in New Mexico.
Obama's moving her into these dorms. Probably very secretly. That's what I just said. She posted something on Twitter about it, like in the spring. So there were like these rumors, but apparently she's on campus. Oh no, the university's never going to confirm it. No, not a chance. But people have seen her on campus, apparently.
Okay, so you guys should be good now.
I can see your slides. Are you good at like presenter format?
Yep, it's presenter. Well, I can do presenter.
Yeah.
Can you guys hear it? Okay.
Yes.
Yes.
Okay.
So are we all otherwise ready to rumble?
Yep.
Yep.
Yep, I think so. All right, Veronica, you can let everybody in.
Okay, great.
And then Steve, you're gonna talk?
No, this just changes the camera. So whoever's talking is gonna. I mean,
Tom, I don't have control of the slides though, so
Just say
Right.
advance.
oh, okay. Well,
Okay, I'm letting people in.
oh, is there? Okay.
Wait, Brian, you can do the first like 4
Yeah.
slides.
Okay.
And then we probably do rotating.
Colleen, just let us know when we are all good to go, and I'm sure that people can start to hear me soon, huh?
Everyone should be able to hear you at this point.
All right, I've seen people in there. I've seen a lot. How many people we have in the room now?
23.
Great. Steve,
24.
I'm going to turn it over to Steve and Alia, who's going to introduce everything. So Steve, take it away.
Great. And I want to welcome everybody to the Journal Club. Thank you guys for doing this. This is Linda Brubaker, in case you can't tell. Okay.
All right, since I'm not hearing Steve, I'll retake over for a moment. This is Tom Gregory on, I think I have my video actually working, so you can see our team here at Portland OHSU, welcoming everybody to our next rendition of the FPMRS Journal and OGS Journal Club, and it's really been exciting to kind of go through and get this going. So welcome everybody, as Linda just said, and what we're doing is kind of working on having essentially live listening into another group's journal club, with us being kind of flies on the wall, but more than just a fly on the wall, we are trying to have a way to be engaged. So I'm just going to go through a couple of announcements and housekeeping, so I just kind of mentioned what we're doing here. The articles you should have received when you got your announcement, and you could read them and download them. And by default, your microphone should be muted, but when you want to sort of say something, there's a way for you to kind of go to your menu and see who's involved, and then raise your hand if you want to say something. Alternatively, we can definitely use this chat room. If you look at the bottom of your Zoom conference, you can find the thing that says chat, and you can see that Linda has already welcomed everybody to the Journal Club. So here's a spot where we can all kind of contemporaneously sort of have a little talk while the folks at Michigan are doing their thing. I also, I guess, want to mention that we've already arranged for our next Journal Club, and it will be October 11th, and it'll be at 3 o'clock Eastern, 2 o'clock Central, and 12 p.m. Pacific, 1 p.m. Mountain. And it'll be hosted at the University of Oklahoma with Steve, Linda, and me sort of moderating as we have in the past.
Tom, I believe it's 1 p.m. Central and 2 p.m. Eastern on Friday, October 11th. It'll come out in a message to all OGS members.
I thought it was 2, so we'll make sure we get the right time with everybody. It's definitely October 11th. Thanks, Steve.
Thank you. This is Lishan, and Steve has the correct time. Thank you, Tom.
I am so sorry. Wrong time, Gregory. So, Megan, if you guys want to take over from your conference room, we're excited.
We're having a little, are you guys seeing our slides?
We see the slide, we don't see the slideshow.
Okay, are you seeing the one that says you are listening in live?
Correct.
Okay, so that's a problem. Okay. Because I've been advancing them, and that's what we see on our big screen here. So we just need to work on that for a second.
Oh, so this is, you want to go to try display settings and then duplicate slideshow.
What do you guys now you guys are seeing the Oklahoma slide, is that correct?
Correct.
That is correct.
Yeah.
We are good.
Perfect. All right. So John, are you ready to? Okay. So Dr. Delancey's going to get us started.
And I just wanted to talk just very briefly about why the hiatus matters. The basic idea of prolapse is that there are two things that go wrong. One is that the connections between the vagina and uterus and the pelvic sidewall fails, and that's what surgeons have spent most of their time on. But the other is that the pelvic floor opens to allow prolapse to occur. And if you think about it, if the hiatus is closed, then increases in intra-abdominal pressure are equal in the anterior and posterior compartment, so there's no resulting force on the pelvic floor. And you can see that in this video when you watch it, and you see the woman straining down. And if you look right here, you can see the anterior wall and the posterior wall getting pushed together. And that happens because the hiatus is closed and nothing prolapses downwards. So the problem comes when the hiatus opens. And if the hiatus opens, then increases in intra-abdominal pressure are not offset by contact with one another, and so there's a pressure differential that occurs. And once the pressure differential occurs, then prolapse can happen. And now you see that the uterus and the bladder are going downwards because the hiatus is failing to keep itself closed. And so the ability of the hiatus to be closed actually has direct impact on what's going on with the apical supports and the attachments. So once you have this part of the vagina exposed to atmospheric pressure through the open hiatus, then you've got a pressure differential. That pressure differential pulls on the uterus, and the uterus pulls on the ligaments. And so that's why you can't really understand what's going on with the ligaments unless you understand what's going on with the hiatus. And I think that there's been a lot of science that's looked at the apex. And I think in the last 5 or so years, we've seen an increasing emphasis on trying to understand what it is with the hiatus that's wrong. Now, in a normal individual, we don't even think about the size of the hiatus because it's closed, and the second photograph is a rectocele, and everybody sees the rectocele, but they miss the fact that the hiatus has gone from 2 centimeters to 5.5 centimeters. And so a lot of the interest now is just about the ability of the hiatus to stay closed and what that has to do with the different treatments, treatment outcomes, and different things that tend to cause prolapse. We tend to be captivated by the uterus over on the left-hand side, but if you push the uterus back in, you can see a failure of closure. And in these 2 very nice drawings from Hallban and Tandler's dissections of normal women and women with prolapse, you can see in the right-hand side the very dilated hiatus. You can see changes in the perineal membrane. You can see changes in the levator ani muscle. You can see changes in the perineal body. So being able to now start into a place where we can start to look at the consequences of enlarged hiatus, I think is going to be really interesting. And I think the articles for today are going to give us an idea about what's going on currently in the literature about some of these issues.
Okay, so we'll go into the journal articles here. I'm Caroline Kaiserman-Schmockler, the 3rd-year fellow here at Michigan. And the article that we're going to start with is the one called Surgical Alteration of Genital Hiatus Size and Anatomic Failure After Vaginal Vault Suspension. So the aim of this paper was to compare anatomic outcomes after native tissue vaginal vault suspension, either uterosacral or sacrospinous suspension, at medium-term outcomes among women who were categorized by their pre-op and 6-week post-op genital hiatus size. Their hypothesis here was that women with a persistently wide hiatus, so greater than or equal to 4 centimeters, will have the highest risk of anatomic failure after a native tissue vaginal vault or suspension. So this was a retrospective cohort study. It was done at a single academic center, and the patients had surgery between January 2005 and August 2015. All of these patients either had a uterosacral suspension or a sacrospinous ligament suspension for either uterine prolapse or vaginal vault prolapse after hysterectomy. To be included, all of the patients had to have a full POP-Q done at 3 time points, so preoperatively, 6 weeks postoperatively, and in what they're calling the medium term, and that included 3 months to 2 years postoperative. Patients were excluded if they had their surgery done by a non-FPMRS surgeon, if there was any mesh or graft augmentation, and if there was any missing POPQ info at any of those time points. Again, they defined a wide genital hiatus as greater than or equal to 4 centimeters. And to analyze these women, they divided them into 3 different groups based on their pre-op and post-op GH size. So the first group, the persistently wide group, had a wide GH at the pre-op and post-op visit. This is the 6-week visit that they make this determination at. The improved group had a wide GH preoperatively, a normal GH postoperatively, and then the stably normal group had a normal GH both before and after surgery. Their primary outcome was a composite anatomic failure outcome at that medium term, that 3 months to 2 years. And this was defined as recurrent prolapse in any compartment beyond the hymen, so a anterior, posterior, or apical prolapse beyond the hymen, or retreatment with surgery or pessary. In total, they included 260 women in the study, and the mean follow-up time overall was 349 days, so just under a year. When they split them into those 3 groups, in the persistently wide group, that included 15% of the women. There were 60% of the women in the improved GH group, and a quarter of the women in the stably normal group. Here they show, or we're showing the first table from the study that shows the basic information. And here you can see that there was a higher percentage of advanced preoperative prolapse, which they're calling stage 3 or 4, in the persistently wide group compared to the stably normal group, and the stably normal compared to the improved group when they do pairwise comparisons. In total, their composite anatomic failure overall was 19%. And they did find that failure was more likely in the persistently wide group compared with the improved group and compared with the stably normal group, and that was statistically significant. They also found a trend toward more reoperations in the persistently wide group compared to the stably normal group and the improved group, but that had a p-value of 0.07, so not statistically significant. The strengths they noted in the discussion were that this was a large study population, they used consistent surgical techniques, they used a clinically relevant categorization based on that GH normalization, and they used a rigorous definition for the primary outcome of composite failure. The limitations they acknowledged were the lack of subjective outcomes, but they tried to use a reoperation as a proxy for that, and the potential for selection bias on the decision for a posterior repair at the time of surgery. And they also noted that looking at the immediate post-op GH still in the operating room may be useful to study in the future, and that was not included here.
There's a question in the chat room. Where does the 4 centimeter cutoff point come from?
I believe that just comes from prior studies.
And am I remembering that their posterior repair rate is fairly low?
Yes, their posterior repair rate, somewhere, I think it was 19 to 30-something%. I think it's in one of the tables.
It's in table 1.
Mm-hmm.
And how might that affect the findings?
So I think Dr. Delancey is alluding to a study that we did recently here that we'll be presenting at Augs IUGA. And we did sort of a variation on this study. looking at the same kinds of groupings, but our patients have a really high rate of posterior repair, so over 70%. And we found a different outcome that the normalizing the GH did not actually affect the rate of failure. So posterior repair might be an important part of the story.
And they mentioned that in the paper as well, of like the concluding sentence of their paper is that maybe consideration to posterior repair is an important part of this. Since the improved group, almost 50% of them had a posterior repair.
This is Tom here asking a question. So that I think that I don't want to take away from the talking about the next paper and maybe further discussions of the physiology behind this, but I think it sort of is something that we all sort of struggle with. Dr. Delancey sort of prefaced all this with the talking about the hiatus and whether or not what we do as posterior repairs are actually functioning on fixing the levator ani portion of the hiatus or working on the perineal attachment or making the skin function of the genital hiatus and when we do our POP-Q. That's always a very challenging question to understand from a physiologic standpoint, even though we might do the surgical procedures thinking that we're addressing the genital hiatus. And so I think that's always something that I'm always interested in sort of thinking through with other people.
Yeah, I think the other thing is that I assume these were hiatus measurements taken during straining.
Yes.
And hiatus measurements made at rest give you a different piece of information because essentially if you have a prolapse that's dilating the hiatus is going to be larger. And whether it was the dilated hiatus that led to the prolapse or the prolapse that led to the dilated hiatus is something that we'll have to think about a little bit more. But it's, I think now we're starting to get data that allow us to be able to actually get conclusions about which things affect outcomes and which things don't.
I think too, you know, the question of what we're repairing with the posterior repair is a really good one, because institutionally and like depending on where you're trained and how you approach the case, we could be doing potentially very different surgeries and calling them the same thing, and that wouldn't be picked up in coding. I mean, both the papers we're looking at today were done within a single institution, and so presumably many of those providers have a similar or identical practice if they were trained by the same people. But really the way we approach things as surgeons is very individualized often.
Yeah, that's a good point.
Oregon. I learned very early on an interesting lesson, and that is whether or not what the posterior repair is what changes the hiatus or something else that we do. I had a patient who needed a sacrocolpopexy and posterior repair. That was my original plan, and based on bleeding, we weren't able to do her posterior repair, and her hiatus normalized based on the sacrocolpopexy alone.
Which is what we'll talk about here in a second for sure.
And I thought that was a really interesting lesson to learn early on, that I could fix the hiatus and never do a posterior repair. So I don't think we should only focus on the posterior repair when we think about hiatus size.
Yeah, and I guess the question becomes which patient, when you take care of the prolapse, hiatus is going to become normal, and which patient, when you fix the hiatus, it doesn't become normal. That would be a great thing for us to get the answer to. Should we move ahead with the next one?
Yeah, I think that's a nice segue. So I'm Peyton Schmidt. I'm the second year urogynecology fellow here, and I'm going to be discussing the second article, Restoring Genital Hiatus to Normative Values After Apical Suspension Alone versus with Level 3 Support Procedures. This was done by Carter Brooks et al. And was recently published in the FPMRS journal. So the aim of this study was to compare postoperative GH in women who underwent an apical suspension without a level 3 suspension procedure to a normative value of GH of 3.4 centimeters or less. And this normative value was based on review of normal patients in their practice. Their outcome was looking at postoperative GH and women with and without these level 3 support procedures, and their hypothesis was that apical suspension alone will remodel the hiatus to normative values. They also had a secondary aim to compare the change in GH when an apical suspension was performed with and without level 3 support procedures, and if this varied by type of apical suspension performed. So this was a retrospective chart review of women who underwent procedures by urogynecology surgeons at 2 tertiary care hospitals, but within the same system, between January of 2019 and August of 2015. The 2 apical suspensions performed and included in this study were either sacrocolpopexy or uterosacral ligament suspension, and sacrospinous ligament suspension was not included in this study. They considered level 3 support procedures as either paraneorrhaphy and or posterior repairs, and it sounds like they could word it, the attendings could word these very similarly in op notes, and so they extracted both. They defined failure in their paper as either prolapse beyond the hymen or retreatment with surgery or pessary. So they had 1,006 surgical cases included. 846 of them, or 84%, were suspensions alone, and they had apical suspensions with a level 3 support procedure of 15.9%. They had a median follow-up, that should be 34 weeks, so just under a year, and they had no baseline difference in demographics, and that's in Table 1. And their retreatment for pelvic organ prolapse was 4.5%, but I did not see a composite for the entire group of the total, what they defined as failure. They just had broken it up into other tables. So just looking at that 15% of women who underwent a level 3 support procedure, those women were more likely to be premenopausal, undergo a concomitant hysterectomy at the time of their surgery, and undergo a uterosacral ligament suspension as opposed to the sacrocolpopexy in this group. And you can see those in tables 1 and 2. And so here's table 2, and concomitant hysterectomy with a significant p-value, and then what apical suspension procedure was performed was also significant. I do want to note here, and this is also on the other slide, was that the majority of the patients in this group underwent a sacrocolpopexy, and they had a much smaller N for their uterosacral group. So GH after apical suspension, so getting at their primary aim, was reduced beyond normative data, so that GH of 3.4 centimeters with a level 3 support procedure, but also without a level 3 support procedure. And here you can see that when there was a level 3 support procedure performed, there was a greater reduction in GH size. And then here you can also see that there was a greater change in GH when they performed any apical suspension, as well as when they performed a minimally invasive sacrocolpopexy alone, but there was no significant change in GH when a uterosacral was performed alone. So postoperative GH in women who did and did not undergo these level 3 support procedures was similar. So there was no significant difference in this group. And there was no change in retreatment or surgical failure rates in women that did and did not undergo a level 3 support procedure. And here you can see they then performed a multivariable logistic regression. And what they found was that an independent factor associated with surgical failure included performance of a uterosacral ligament suspension and a greater preoperative GH. However, they did not find that level 3 support procedure alone was independently predictive or a prior hysterectomy. They then performed an ROC curve. This was only for the minimally invasive sacrocolpopexy. They weren't able to do an ROC C curve for the uterosacral, likely because of their smaller N. And what they found was that they located a cut point, essentially, of a GH greater than 4.75 centimeters. And so they're saying that that's kind of the point at which they would consider doing a posterior repair to restore the GH. So in conclusion, the apical suspension procedures with and without level 3 support procedures did reduce the GH to less than normative values. There was no change in failure rates with and without level 3 support procedures, but the independent factors associated with surgical failure included uterosacral ligament suspension performed and a greater preoperative GH. So limitations, there are some limitations with this study. One is just the retrospective nature, and it's a convenient sample. Certainly there's probably some selection bias just in terms of when a surgeon is deciding on what type of apical suspension to perform, and then also whether or not to perform a level 3 support procedure. It's a somewhat skewed population with a much higher percentage of patients undergoing sacrocolpopexy than uterosacral, and a fairly small posterior repair rate overall, and then just short follow-up. And I thought I'd open up the floor to discussion now.
Peyton, do we know whether the two groups were comparable in terms of pre-op prolapse size?
They did discuss that, yes, and there was no baseline differences in terms of preoperative prolapse stage.
And is there an idea about how big these prolapses were?
Yes, most of them were level 3 or 4. So between 66 and 68% were level 3. Stage 3, thank you. And then about 10% were stage 4, and only 20% were stage 2.
So they didn't really provide a maximum prolapse size.
It would have been nice to have them control for that with a logistic regression.
Mm-hmm.
The pre-op GH size is kind of a surrogate for that, but that's still not quite the same.
Yeah.
It would have been nice.
And these were primarily primary prolapse operations, not recurrence?
I did not see that they reported if there are prior prolapse surgeries.
It was prior hysterectomy.
Yeah.
They report.
Yeah.
So I don't have a great sense of what their patient population was like, and if that differed for someone that got a sacrocolpopexy versus someone that got a uterosacral ligament suspension, which could potentially impact outcomes.
And there's some people who do sacral colpoperineopexies.
They described that most of, at least what I understood from the method section, was that they do go down to the perineal body during their sacrocolpopexy.
Which is different than the standard sacrocolpopexy.
Right. So I think that gets back to Dr. Fairchild's point in that many surgeons are doing what we're calling the same surgery, but doing them very differently. And so it's hard to compare outcomes.
One thing that I found interesting in looking at the folks that got the level 3 support procedures was the higher rate among premenopausal women. Just because I think in my own practice, when I see a premenopausal, and typically I find that population to be a more sexually active population, I'm less likely to perform that posterior repair. So I wonder what factors there are driving the fact that their rate is higher in that group.
Or if they were also more likely to have the vaginal
surgery.
Uterosacral.
Yeah.
But
Yeah.
we don't know.
I think that's the connection there.
When I remember Al Addison, who was kind of the father of sacrocolpopexy in America, saying that there was an inverse relationship between the number of adhesions that you encounter during a sacrocolpopexy and the likelihood of doing a posterior repair. And I think that if you're approaching things vaginally, we saw here that people were much more likely to do a posterior repair if they were operating vaginally than if they were operating abdominally.
John, Tom Gregory here. I think that is a important point that if we all sort of reflected on our own practice patterns honestly, we would, when we're doing abdominal surgery, whether it be open abdominal surgery or not, I think that whether it's laparoscopic, I think that there is some tendency that the length of the surgery, the fact that you're not actually looking at that spot when you're doing vaginal surgery that perhaps affects your decisions to do the posterior repair, whatever we're doing to try to manage the GH. I think also we've been sort of, I think you mentioned it early, that we are managing the apex, we are managing the loss of the ligaments, and we think, oh, hey, we are addressing the apex, the anterior compartment, and to some degree, whether you go all the way down to the perineal body or not, the posterior compartment, we think we don't need to address the actual final level 3 support because level 1 and 2 are well supported, and therefore we've overcome that. And so, I mean, I know that I think about how I've evolved, and that some of the things that I think I've thought through.
The other thing would be for everybody to write down honestly what their algorithm is for deciding whether they're going to do a posterior repair or not. And then, as Pam pointed out, people describing honestly what they actually do and what their therapeutic goal is when they're doing a posterior repair. Because I listen to a lot of people talk about the fact that they think that there's an isolated defect in the fascia that they are repairing specifically, and I don't hear them trying to reconnect the separated margins of the perineal membrane. And so I think that as this data evolves, those kinds of distinctions will become important for people to start to actually look at. And, there probably will soon be enough preliminary data that actually randomizing patients, which would give us stronger data, would be a perfectly logical thing to do.
And thinking about the importance of randomized data to kind of support these theories that people are having about the importance of GH normalization, one really strong weakness, I think, of this is that the data are not blinded. These are likely surgeons looking at their own results. And I think, as a surgeon myself, it's really hard to look at your own result and then see somebody at like 3 months post-op and be like, oh yeah, that anterior wall's -1, -2, and I think it's just a hard thing to use that as research data and really make hard conclusions when it's not blinded.
Yeah, good point. Are there any questions coming in from the members who are listening in?
Yes, so there's a question about, so looking at the substantially higher odds ratio rate of failure for the uterosacral surgery versus the sacrocolpopexy patients, looking at whether this is reaffirming that maybe advanced prolapse is more likely to fail when native tissue surgery is done, or is this just a different question asked of the data?
Well, there was no difference in pre-op stage of prolapse. So I don't know that we can make a conclusion about the uterosacral not being appropriate for advanced stage prolapse. And maybe it's the preoperative GH size is that's a surrogate for prolapse size, but I don't think it's quite the same thing as maximum pre-op prolapse size.
I do think, though, that this same database, if it's the database I'm thinking about, was used in another study looking at that question exactly, which is uterosacral sacrocolpopexy. And they did find that with larger prolapses, the sacrocolpopexy performed better. And I believe it was the same data. It was out of Pitt, and I can't remember the first author on it.
They did use this. They said it was a previously.
Yeah, and I think it's the same database that they used to look at that, and they did find that with the larger prolapses, the uterosacral didn't perform as well at their institution.
Can we also, I was going to send a chat, but can we also explore what the receiver operator curve really is telling us? Because at first glance, if you don't look at this carefully, I think it tells you that your cut point for doing managing the GH would be 4.75, but it's basically saying that's when they decided to manage it, and that has nothing to do necessarily with outcomes, correct?
Yeah.
Yes.
Right. And I guess in my own practice, I have literally seen a patient whose resting genital hiatus was 2 centimeters, and her straining hiatus was 5 centimeters. She doesn't need a posterior repair. Her pelvic floor closure is perfectly fine, and it's just that the prolapse is dilating it. There are other people who have a resting genital hiatus of 4.5 centimeters, whose straining hiatus is 4.5 centimeters. And I think that that's the nuance that we're missing. It's also, most ROC curves have a value that tells you how much of the phenomenon it explains. And this, you'd like to see that inflection point way up near the number 1. And so it's not a particularly strong relationship in this data set. I'm also wondering why they excluded sacrospinuses.
I don't know. They did not mention sacrospinous, so I don't know if it was that they didn't have a high enough number or that they don't.
My guess would be that they don't have a high enough number
to include.
Yeah.
Yeah.
Yes. Or that, that was a PFDN site, and some of this data is at the time when they were working on the sacrospinous with the mesh, and they excluded mesh. And so many of their sacrospinuses may have had mesh augmentation.
Interesting.
But I think the point is well taken about this ROC curve, in that it doesn't tell us anything about the likelihood of surgical failure. It just says that this is when they decided to do the posterior repair.
4.75 is the whoa, that's a big value.
Yeah. Are there other questions that people who are listening in have? I think you can unmute your microphone and ask them, or you can type into the messaging.
You can also raise your hand if that is more appealing.
Well, this is Steve Manalia in Hawaii. I'm in New York right now, but I would say that just kind of building on what Dr. Delancey just said, and this is what I was hoping the group would kind of discuss, is really how both of these articles integrate to kind of form a consolidated piece of information. And one of them is, I think, in my opinion, that we should be subtyping these patients as far as, do we just fix the apex and not do a level 3 procedure or not? And I think certainly that's what the Carter-Brooks paper is speaking to. For a moment, what I would suggest is this. In a way, if you think about a stage 3 or 4 prolapse, it's almost an exaggerated, example of it's exaggerated physiology, aka pathology, right? And so we all know that with someone with a prosthedentia, the level 3 support could be dilating in response to it. So this is almost like an exaggerated, physiologic process of labor, if you will. And there's some data that's also mentioned in the papers that if you put pessaries in patients, sometimes the level 3 support, or at least the genital hiatus, will kind of normalize because you're taking the pressure off of it. So I think it's safe to say from both articles that the routine posterior repair shouldn't be so routine, and that perhaps now we're moving towards subtyping patients to identify who just gets an apical procedure, who gets an apical procedure and a level 3 support procedure, et cetera.
Yeah, that's a good point. It's, I think that at least in listening to people, the decision tree that they use to decide whether to do a posterior repair, there's really no unanimity of opinion around the country. And I think part of it has to do with what people believe level 3 is, and how level 3 is what the mechanism of level 3 support is. You can have two people with the same hiatus size, one of them who can generate 3 to 4 newtons of force when they contract, and another of whom only gets a little flicker. And so here we're just looking at a static dimension at maximum strain, and we're not really looking at whether the muscles are innervated and respond to force, or whether the muscles are completely denervated and don't close. And I know, Tom, you've done a lot of work on innervation to know that there's some people where, boy, the muscle is there and it's just stretched. And if you get the load off of it, it's going to recover and be just fine. And I wonder if starting to add a little bit more richness to how we're looking at level 3 with ability to contract, ability to generate force, ability to normalize the hiatus might be a way forward in terms of trying to have a little bit more comprehensive. I always think about it as it's kind of like saying, does somebody's hand work or not? There are a lot of things, is there somebody play the violin, can they play the piano, can they just basically grip and that's it? Or do they have a complete neurologic injury and their hand is just flaccid? If you're just measuring dimensions, it's kind of hard to know about all those functions. And I think that that may be a growth area for us in terms of trying to understand things a little bit better.
Absolutely.
I can tell you that thanks to Mandy Clark, we've been thinking about the levator function, the pelvic floor, whatever we want to call it, function more than just the measure of the GH either at rest or with Valsalva in a POP-Q. And so, whether or not we've been giving ourselves any more information by measuring, even just using a scale, you can, the Newton force that you describe. But I would say that up till now, I have not used that in my algorithm to choose to or not do a level 3 support procedure, but rather make decisions about augmentation of the remainder of the compartments with mesh or not. And that's how I've plugged it into my thinking. Whether that's right or not, obviously we don't have any data.
And I suppose the other thing is, which of the posterior repair techniques have the lowest dyspareunia rate? And our dyspareunia rate, I have to say, is not very high here, despite doing posterior repairs in about 70% of patients, because I think over the course of time, we've evolved a technique that doesn't distort things a lot. I periodically ask the fellows, have you seen a patient present with dyspareunia after posterior repair because of the posterior repair? And with a careful repair done, it's possible to achieve relatively low rates. I think everybody was scared by the publication of a 25% dyspareunia rate. But when I looked at what the people at that institution were doing, they were doing something that was way outside of, I think, what any of us would do. And Mandy, did you spend time with Stuart Stanton?
Oh, yes.
It was a pretty aggressive operation, as I remember. Is that right?
Yes, but I don't recall. I mean, the follow-up in the National Health Service is not such that we really knew whether they had dyspareunia after that or not. We didn't see it a lot, but we didn't elicit it a lot.
Yeah.
The other thing that I would say about, I've been doing a lot of work on the genitourinary syndrome of menopause and dyspareunia related to that, and I've noticed that when whoever is asking the question about dyspareunia, they assume that the question is about the subject of interest. So when we ask it in a Urogyn setting, we're thinking, oh, did the posterior repair cause it? When they could have GSM, they could have a yeast infection, they could have vestibulitis. We don't ask specifically or know enough about the question of dyspareunia to really understand the answers we're getting back.
I think too, many women may be self-conscious prior to prolapse repair and they're not particularly sexually active. They get their prolapse repair, they feel more confident, they feel more sexual again, and then perhaps there's been a year or two since they've had intercourse and then it's painful. And that's, again, potentially not related to the surgery.
Yeah.
I have another thought that hasn't been brought up that I've heard John talk about this before, and that's how vaginal length affects what happens at the hiatus. When we first switched to the minimally invasive sacrocolpopexies, I had a hard time figuring out tensioning because I was worried about the intra-abdominal pressure. So I'd go down below and look and have the fellow do the lifting while I looked at what the perineal body does. And it both moves cephalad when you pull on the mesh, and it also moves toward the symphysis, towards more closure. And when you have a sacrocolpopexy, you can pull up as much as you need to get things lifted. But if you're doing a vaginal procedure, you're more limited, and you may have to shorten the vagina, especially if you're going for the sacrospinous ligament. And that's not something we talk a lot about. So that I think vaginal length is another factor to consider in what ultimately happens to the hiatus and how we fix things.
Yeah, it's a good point, Mandy. I see a lot of body language going on in the room here because we very specifically, when we do a Michigan four-wall sacrospinous suspension, we spend a lot of time making sure that the vagina is exactly the right length posteriorly so that it reaches the ligament and it takes out all of the slack in the posterior wall, which is, I think, is very different than the Nichols-Richter technique, where you're basically only getting one corner of the vagina up. So I guess I would agree with your point with the Nichols-Richter technique, which is the standard one that everybody knows about. But we did a paper a number of years ago on vaginal wall segment lengths and the size of the diamond that you remove. And when I watched some of the people in the PFDN doing the Michigan 4 wall, I realized that that was one thing that they didn't necessarily understand, was the need of making the incision on a place on the posterior wall so that all of the laxity was gone. And so that might be another area for us to look in, is just whether people were getting adequate posterior elevation. And it's probably more difficult with a high uterosacral, simply because, you know, I don't do a lot of those operations, but it seems that there isn't as much attention paid to where you make the incision. You just kind of make the incision on the cervix and then attach it. Whereas with the Michigan 4 wall, we're always kind of testing what that length should be. Might be something for us to think when we're doing uterosacrals about, when we make our incision, whether we want to tailor that.
I know Dr. Fenner has talked about doing it in the Mayo style, where there is some excision of vaginal length at the top.
With the McCall cultoplasty.
Yeah.
Yeah, and that I think does a much better job. Are there any of the people who are Mayo trained that are on the call? They're all in the operating room.
So there's a question in the chat, another clinical problem that besides dyspareunia that sometimes influences the decision can be obstructed defecation. So if you're looking at your decision tree, if a patient has obstructed defecation with splinting and a GH of 5, to get the posterior repair, but if there's no symptoms, is that a patient who could avoid a repair? That's what they're saying. So that's the question: does the obstructed defecation tip the question?
Yeah.
I think if you have somebody with adequately managed bowel habits, who you know has a functional pelvic floor as far as evacuating their bowels, that they're not obstructed for one of the other several reasons why you might be obstructed, I think there's a role for the posterior repair there. And certainly if you have someone that has a relatively normal genital hiatus and no obstructive defecatory symptoms, that's something we write up on the board in the operating room. Like as far as the clinical note, did this person report splinting? And so I think it certainly plays a role for a lot of us here. But obstructive defecation is a bugaboo, right?
Yeah.
I mean, if you look at the data for that, some studies report great rates of improvement with posterior repair, and in others it's more like 40 or 50%. I think that's probably because there's very many ways why somebody might have obstructed defecation, and posterior wall support is one of them. But it's also a chicken or the egg kind of thing, where people that are chronically straining, chronically constipated may give themselves a rectocele, and that's not causing their defecatory dysfunction.
Well, just to
Can
point
you
out,
all hear me? Can you all hear me? By the way, I think my audio wasn't working a while ago. This is Leishan. I wanted to make a point that maybe needs to be rewound for like another 5 seconds real quick. Going back to the reassigning of the apex, I think that that's a very important point brought up by Dr. Delancey, and I know some of you have echoed that. And I think it is something that, for example, when I was trained, I was instructed in trying to make sure to do, because if you do have a posterior vaginal wall that has a significant rectocele, and you are just making that incision near the cervix, then when you do that uterosacral ligament suspension, you're not going to get that tailoring effect that you want with that pelvic floor reconstruction. It goes along in parallel to that point that Dr. Delancey brought up with that, the 4-point Michigan suspension. And I routinely also instruct my trainees to take that same approach whenever we do sacrocolpopexy post-hysterectomy or sometimes after hysterectomy, for us to reassign the apex, quote unquote, to try to make it so that we're able to, provide that level 1 support addressing all aspects of the anatomy.
Yeah.
Thank you, guys.
It's a good point, Leishan. And I think that that's something that doesn't always necessarily get taught. If I can put a plug in for Natalie Karp's video that people might want to look at that covers that as one of the things about tailoring 4-wall sacrospinous. If there's a website called SmugMug. And we have a PFRG site. And so if you just type into your browser SmugMug and then PFRG, on the front page, you'll see one little panel that says videos. And if you look for no slash, just they should just Google
Like that.
Yep, just a space between SmugMug.
Like that.
Yeah.
Okay.
If you just put that into Google and then look on that page, it's got other things that our group has on there, but there's a thing that's on videos. And one of them is about what Leishan was talking about reassigning the apex and how important that is. And I think it's a visual way for people to understand that.
I wonder too about reassigning the apex with sacrocolpopexy. If you're doing a supracervical hysterectomy and you have a very long vagina, I think you have to be really careful about how to do that. And I wonder if some of the Y meshes that many of us have transitioned to using don't allow that kind of customization, because you can't easily manipulate where the apex is because it's kind of predefined. And maybe that when people that are taking that two-armed like kind of customization approach are getting a better redefinition of the apex.
I agree. That's a little bit more difficult with the cervix in place, rather than if you're doing a total laparoscopic.
Sounds like we have a lot of research left to do, doesn't it?
Yep.
So can we have perhaps the presenters make any summary statements about the two articles and kind of what directions to head, getting back to the literature?
Sure. So for the first article, I would say the summary is that they showed that failure to return a enlarged GH to a normal GH with surgery, native tissue repair, is associated with a higher rate of anatomic failure. And then future directions would be what we've started to try to do is look at the same question in different practice patterns to kind of look at some of the other factors that are contributing to failure.
And then for the second paper, the Carter-Brooks paper, they showed that doing an apical suspension can restore the GH to normative values, both with level 3 support procedures, but also without. And I think that future directions with this study would be looking at who needs a posterior repair in terms of what's going on actually with the genital hiatus. Is it being abnormally dilated by a large prolapse, or is there something actually functionally wrong with level 3 support, and in which case a level 3 support procedure would be indicated?
Yeah, I think those are fantastic summaries. And basically our next task is to figure out how to subtype these patients to those who really don't need it versus those who need it. But would most of you all agree that it shouldn't be a routine per se and that it has to be individualized in all cases?
Yes.
Right.
Absolutely.
Yeah.
And then the other thing I would say about Carter-Brooks is keep in mind, I don't think this was stated explicitly, but they're combining perineorrhaphy and posterior repair into one group. And I think when it comes to surgical outcomes, we really have to homogenize the surgery technique as much as possible. And for me, at least, the big confounder with the sacrocolpopexy group is they are, in fact, taking the mesh all the way down to the perineal body, which almost sounds like, they're just doing a trans-abdominal level 3 support procedure. So it's difficult if you're mincing words, but when you get really into the depth of these papers, you see a lot of these limitations kind of glaring. Tom, any comments?
No, I think you've you've hit on it. I've been thinking about this for 15 to 20 years as well. So figure out how to
My entire career. Okay, well, I'd like to thank the presenters at University of Michigan, as well as helping us coordinate this and keeping this journal club afloat. And as we talked about at the beginning, and we do have Dr. Leishan Kuroz online here too, just to correct. So the October 11th, 2019, it's a Friday. It's going to be hosted by University of Oklahoma. And again, to correct the dates and times, it's 2 p.m. Eastern, 1 p.m. Central. And that will be the same format, and hopefully we can continue to build this process with the more participants. Thanks to everyone who joined today. Thanks to Dr. Brubaker, who also is making herself available for all of these journal clubs. And again, thanks to my co-moderator, Tom, who's really doing a ton of work behind the scenes.
Thanks, everybody.
Thank you. Looking forward to it.
Okay, we stand adjourned.
Thank you. Bye-bye.
Okay, bye now.
Are we off? We talk. Yeah.
I'm here if anyone else has anything to say. How do you think it went for those of you who are still on?
I think it went great. Can you hear us still?
Yes, is this Megan?
Yep.
Yeah, tremendous job. I appreciate you getting the fellows involved and your other faculty. Dr. Delancey, thanks for joining us. And this is how we envision it. And we are going to be generating a survey to try to develop this further and see where the sources of improvement might be.
I think it would be awesome to invite the authors.
Huh.
That would be very strong.
Yeah, I asked Jerry Lauder to join, but I think he's on a plane somewhere. And then he asked me to get John Shepard involved, and I just didn't connect with him. But I do agree. I think that's where we're going to be headed. Not to grill them or quiz them or make them feel inadequate, but to say, hey, you know, what were you thinking when you did this?
Yeah. How do you do a posterior repair?
What's your technique?
The other thing is trying to find ways to encourage the people that are listening in to ask questions. I know it's a little bit cumbersome when they see all these different people, but I think maybe if we went through in the beginning and just kind of said, everybody practice raising your hand so that they know that that function is there.
Yeah.
And maybe everybody just type one brief thing into the messages just to make sure that they know that those functions are there. But I think it went really well.
Yeah, it's funny because Tom asked me to moderate, but I didn't even realize my mic had muted itself automatically after talking to you before the thing started. So yeah. There's a lot of the tools on the actual Zoom platform that I think have yet to be figured out.
Yeah.
But okay, well, thanks, and I think we'll end here, and appreciate you guys again, really, more than you know. Thank you.
Great.
Kudos to everybody. Thank you.